Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to talk about flared incisors. And I have a ton of videos about, well, not everyone that has flared incisors has overjet. So I'm going to specifically talk about flared incisors on their own. We're going to leave the whole overjet thing out of it. A lot of patients with a class 2 division 1 type of bite have flared incisors and overjet, but you can have class 1 patients that have flared incisors and no overjet. So how you're going to deal with it is really, first of all, that would be my first question. Second of all, we need a lot of additional documentation for any case with flared incisors, and it's a completely different animal for growing kids than for adults, let alone adults with periodontal disease. I'm going to put it in 3 different buckets. Growing kids, because I can modify this. This makes life a lot easier. Adults with healthy bone and teeth and gums, no recession, no past or present periodontal disease, no bone loss, anything like that. And then adults who have periodontal disease, 3 different buckets. So we're going to talk about a little bit. I'm mostly going to focus on the second 2 because I have tons and tons and tons of videos about growing kids and overjet or habits. Because in a growing kid, flared incisors is either caused by a habit or it's caused by class 2 div 1, which of course we can fix that, right? Easy. So if you want to watch those videos, first of all, I highly recommend my phase 1 course, which was just launched. We have a version without CE and a version with CE. The CE one is actually cheaper, believe it or not. And I do have some promo codes. They're kind of buried on my website, so you got to go find them. Dig around on my website. You'll find it. You'll save a lot of money if you find that promo code. I only have a limited amount, so as soon as my promo codes are gone, you will not find it on my website anymore. If you can't find it, you can always email me and I'll send it to you. info@straightsmilesolutions.com or go to straightsmilesolutions.com. But yes, you can get, it's going to be $125 off. So right now the course I believe is somewhere in the 300s for 13 units of credit. That's insane. You do have to take a 65 question quiz, but it's not crazy hard as long as you somewhat pay attention during the course. You don't have to take notes or anything like that. I really didn't make it that hard. So do that, okay? And that's how you'll learn about growing kids and flared incisors. Now let's talk about adults, flared incisors. Let's not even talk about overjet because I have a lot of videos on overjet. If you want to search those, they're free. You can go to my YouTube channel, which is Straightsmile Solutions. You can search by keyword. There's a little magnifying glass towards the top right within my channel, and you can put in proclination or something like that, and it should pop up. But of course, you need more information, right? And the treatment is going to differ depending on what we see. So the first thing I would check anytime I have an adult with flared incisors is I'd get a ceph. I mean, I'm sorry, I know you guys hate getting cephs, but you absolutely need a ceph on these patients. I mean, yes, Invisalign does have that CBCT feature, and I'm learning how to use that without numbers, and I love it. I love it in terms of treatment planning Invisalign, but without those numbers, sometimes I feel a little bit like I'm guessing, so I still think a ceph is better. If you can do the ceph and the CBCT and upload it to Invisalign, if it is an Invisalign patient, that's fantastic. If you have an iTero, but that's nice too. Both would be great, one or the other. If you want to know about cephs, how to read them, how to get numbers, I have a whole channel just on cephs. You can go to my YouTube channel, scroll down, cephs are on the homepage towards the bottom, and there's lots of videos. I also have a ceph handout. Because it's not my content uniquely, I will give it to you for free. Anything that I made, I do sell in my store. So all you have to do is contact me and I'll be glad to give you a copy of the ceph handout, which is an easy way to go ahead and understand a little bit more about how cephs work. Now, if you really want a ceph course, that is not something I'm interested in doing. It's so boring to me, so sorry. Cephs are necessary, but I'm not saying I like to teach them. So I do have my little friend, my big friend, Dr. Rishi Popat. He does the more academic courses. He went to Harvard. He loves academic stuff. He loves literature review. He loves that kind of teaching. I like the more practical teaching, so we tag team. Although he is part of our team, he charges independently, but he will give you a little discount if you are a Straightsmile Solutions client. So if you go through me, I'll refer you to him, and he'll probably hook you up if you are one of our clients. So yeah, he'll do a ceph course for you. So definitely, and his prices are super affordable in my opinion. For his time, given that he's an amazing orthodontist who's done research, went to Harvard, everything like that, you can definitely learn from him. He can teach your study club, whatever you want to do. Anyways, if you want to access Rishi, you can go to Dr. Popat, my website, and look under courses. You'll see him towards the bottom on that tab. All right, so get the ceph numbers. Easy to get if you don't know how to get the numbers once you get the ceph. Let's look at the numbers. So 2 points I'd be looking at on the ceph. First one would be, now granted, I like the Steiner analysis. That's just how I was trained, okay? There's a bazillion different analyses, so I don't know all the points. I only know the ones that I know, and it's enough for me. So one I'd be looking at would be upper incisor, upper 1 to SN. That is the reference line selenosion, which is the cranial base. It is an angular measurement which determines the inclination of the central incisor relative to the anterior cranial base. In layman's terms, that means how is our incisor relative to the skull, okay? Is it forward, is it behind, things like that. A smaller than average angle indicates that a more upright or retroclined incisor, lingually or palatally inclined, we're talking about upper incisors now, as seen in a class 2 division 2 case, a greater than average angle, and an average standard deviation is usually around a 103, plus or minus 6 degrees standard deviation. So greater than average angle indicates proclination or labial version or flared incisors, okay? Which would be more like a class 2 division 1 case. So that'd be the first thing I'd look at. Second thing I'd look at would be upper incisor to NA. That's another one. Now instead of the cranial base, we're giving the incisor relative to NA point, which is another point. Nasion is a point that is within your skull, but A point is a point on your maxilla. Okay, so the relationship of the maxillary central incisor to the NA reference line, it establishes the position of the maxillary incisor relative to the maxillary apical base, both the inclination of the long axis of the incisor and the distance, blah, blah, blah. Okay, so labial, if it's flared, you're gonna have a greater than average angular and linear measurement, okay? So the average is 22 degrees plus or minus 6 degrees standard deviation. The linear is 3 millimeters plus or minus 2 millimeters standard deviation. If it's an upright incisor, you will have a smaller than average angle and linear measurement, okay? So positive values are recorded if the labial surface of the incisor is anterior to the NA line and a negative if it's posterior, okay? All right, boom. So that's what you need to know in terms of cephs. So now if you look at this case and it looks like they're flared, first thing I want to know, is it normal? You know, is it related to the bone? Is it related to the maxilla, the position of the maxilla, or is it caused by something else? And very, very often, anytime you see a flared incisor, it's related to an external force. So let's talk about external forces. I have a zillion videos on OMT and habits. So you'll want to go ahead and review all those videos on OMT and habits. There's a really great screening for it. Again, it's not mine, so I'm glad to give it to you. I think it's called the Ferris assessment, and it's used by OMTs, oral myofunctional therapists. A lot of things you can look at in terms of the tongue and habits and things like that, but you definitely would want to use that form to screen them. We're looking for things like tongue thrust, mouth breathing. I would do a sleep assessment, a kid's or an adult one, depending on which one you have, and see, you know, could something be causing this? You know, could an external force be causing the flaring? Because if so, you shouldn't even try to fix it unless you get rid of the force first, because it's not going to work. I don't care, even if you do a bonded retainer, it's not going to work. Not only is it going to be really difficult and you may not even get there, and you might take way longer than normal if you even get there, but it won't stay. Even with a bonded retainer, even with an Essex over, it will not stay. I can't tell you how many times in my practice, past, present, we see patients that come in that have had relapse, that have bonded retainers, that have Essex, they wear, you know, it's stuck, it's a bonded retainer. How can it relapse? Well, the tongue is a heck of a lot stronger than a bonded retainer, and weird things will happen. So if the doctor fails to recognize that there is a habit, you know, by not doing an OMT assessment, and if you're not comfortable with the whole OMT assessment thing, you can work with an OMT. You can even have your hygienist trained in your practice to be an OMT. It's only a 3 or 4 day course, and you can bill separately. It's another great revenue stream for your practice. But I highly recommend that you do get trained up on OMT, whether you take a course and actually certify someone in your office, or you just learn about it, because if you're gonna think about doing ortho, you need to understand OMT, or you're gonna have a lot of failures. Or if you don't wanna learn it, fine, find a virtual one, find one in your town. I mean, most of the ones in your town, there's 2 different types of OMTs. There's the dentally related ones, and then there's a speech and language therapist ones. If this is a dental type of problem, unless the patient's having major speech issues, I feel like you should pick the dental ones, which are usually hygienists. They're sometimes dentists, retired dentists. But in order to be an OMT, you either have to be a physician, a speech and language pathologist therapist, speaking language, SLP, a dental hygienist, or a dentist. Those are the 4 people that can get certified in just a few days as an oral myofunctional therapist, which is basically like a physical therapist for the tongue and mouth, okay? So many things to learn about this. I just recently went through therapy. It was a 10-month series. It was a lot of work, and it wasn't cheap, I'll be honest with you, but I feel like I got an amazing value about it, not only in my sleep, in my airway, in the way I pronounce words. I did end up having a tongue tie release, which has helped immensely with oral facial pain. I mean, it was a win-win-win all around for me. Totally unexpected, all the benefits I got from it, even health and physical benefits, and you should definitely watch all my videos on OMT to learn more about that. So those are the things I would do to analyze a little bit more what's going on. Obviously, we don't want to be leaving teeth in an unstable position. Why? Because you'll get root damage, you'll get root resorption, you'll get devitalization of teeth. It'll look bad, it will function bad, they can become loose, and there's a lot of other things going on. So we need to fix it. How we fix it? Well, it depends on what the problem is. It also depends on what the ceph says. And we can go from there. But quite often it involves interproximal reduction, or usually extraction of the 3rd molars. You can distalize, and there's a lot of different ways you can do that. And of course, if there's a habit, you got to get rid of the habit first. All right, hopefully that was helpful. Thanks so much.